okay, parents, your kids are going to turn out just fine.
This episode of the podcast is brought to you by FOCO. That's FOCO, F-O-C-O. If you are a parent of a child or teen with ADHD, you know how challenging it can be to keep them focused and engaged. FOCO is the all-natural solution for ADHD, whether it's for school, homework, or just everyday activities. FOCO helps your child or teen stay calm and attentive. Before trying prescription drugs like Adderall that can come with harsh side effects, I recommend you try FOCO. Visit ThinkFOCO, that's ThinkFoco, thinkfoco.com for more information. Okay, welcome to the Your Kids Will Be Fine podcast. Dr. Michael Milobsky, board certified pediatrician, parent of 7, grandparent of 3, with a very special guest, Dr. Alana Arnold.
Hello.
Dr. Arnold is a board certified pediatric emergency specialist, currently practicing in the Philadelphia area, and also can you tell us about your two companies, your two personal projects, Dr. Arnold, that you?
Yes, absolutely. Well, first off, thank you so much for having me.
Yeah, pleasure.
And so, yes, I'll start off with the first company. The first company is called PenPal, and it is a hospital-facing company where we focus on pediatric readiness and basically how prepared ERs, urgent cares, hospitals are to care for children. And so this is critically important because, as some of your viewership may know or may not know, about only 5% of hospitals in the country are dedicated children's hospitals. And the issue is that a lot of these facilities, when you go to your local ER urgent care, they're seen by people not like us, not pediatricians, but general ER doctors or a nurse practitioner, physician assistant, et cetera, who doesn't have dedicated training. So our work focuses on making sure that those clinicians have the proper training, we do simulations. And the biggest thing that we're really working on and excited about is basically a health tech solution, a clinical decision support tool is what you would call it, that helps the clinician in real time get access to protocols and kind of lead them through the management for the patient. So it's a plug-in into the electronic health record where they can access protocols, and it's essentially like a chat bot where you give information that tells you what to do based on the information, like vital signs, clinical symptoms, and things like that. And so it's really something that's critical because, especially in like suburban areas or rural facilities where there's few pediatric facilities, it really helps support those clinicians to give better care. And we've also seen financial incentives about it in terms of like decreased rates of transfer and revenue recapture because the hospitals are able to keep those patients in their system. So it's really a win-win. So we're very excited about that. And, looking to expand and get some pirates going and things like that. And then the second company focuses on, it's called Parent Partners. It focuses on kids' health literacy. So it targets parents and families to basically help them facilitate and understand better what's going on with their child. So we have a lot of programming. It's in an app form where we talk about bread and butter topics, asthma, obesity, nutrition, weight management, mental health issues that may arise in the pediatric population. And with that, we have multi-level content. There's written content, there's video content, there's also chat features, and we also do group visits to bridge the care so when they're not in your office and being able to see you, how to support the family in between visits. So it hopefully really builds a community for the parents and the families to make sure that they're getting the knowledge that they need, that's evidence-based, embedded, instead of just like scrolling TikTok University, as people will call it. Sure. And then also just making sure that they feel empowered around what's going on with their child. So those are the two companies that I have so far.
So it's very interesting. I practice like many community pediatricians. I started as a pediatric ER doctor for a long time, and then I opened up my own practice about 11 years ago. And even though we're not rural, the most accessible hospitals are community hospitals.
Absolutely.
who do not have pediatric departments. And
Okay.
and this is Metro Denver. We're not in the middle of nowhere.
Yep.
It simply is a matter of most community hospitals don't have the ability to afford pediatric care in that setting because it's really only busy for 2 or 3 months, and service, the pediatric volume does not support maintaining pediatric people providing care the rest of the year. It's the eternal struggle of all of our community hospitals, yet
Right.
it's the most accessible hospital.
Yes.
So, I feel like this is an amazing, opportunity for these hospitals to, without it enduring the same expense of having a pediatric staff, to have just much more pediatric competence and still be able to provide that care. So many of our patients end up at the community hospital, and honestly, their care is atrocious a lot of the time,
Absolutely.
especially for the youngest patients. Um, so I think it has a lot of applicability, not even just in low access places, but even places you wouldn't think have
Oh,
access
yeah.
problems. But the community hospitals are situated closer to a lot of the pediatric care than our tertiary care children's hospital, which tries, but that's almost a 20-minute drive away.
Yeah.
So a lot of the families in our community, which is very child heavy, end up at the community hospital.
And you're exactly right, because even in metropolitan areas, if you're lucky, you have one children's hospital, and they're bursting at the seams, right, due to the volume that goes there. And so,
Yeah,
especially as a parent, you want to get access to care for your child as quickly as possible. So it's logical that you go to the closest facility. And
right,
unfortunately, many of those facilities, as you stated, there's just not equipped for it. The average ER doctor has maybe 10 to 15% of their training focused on kids. And that's if they have the benefit of being attached to a children's hospital or something like that. And then they
right.
just kind of released into the community to do the best that they can. So our goal with Pen Pal is really, it's not a blaming game or anything, because God knows I can stabilize an adult, but then I'll shove them onto the closest general doctor I can find. But the goal is really to give them the skills and meet them where they're at, because the kids are going to come regardless. And so how do we support them in that arena? Because like you said, it is a numbers game to have an inpatient pediatric unit and to maintain that and keep that open. But on the side, as you well know, in an ER, everyone comes to the ER at any time of day. And so you have to be prepared. So it's kind of even if you have that lower volume, it can be high acuity if you get a sick kid. And if God knows, like when you're in the ER setting, you need it. And so the competencies, the equipment, all of that stuff is critical. I think also on the flip side, what we're trying to do a lot, I'm doing more speaking engagements and things like that, to just get awareness around it, because the families don't know that. They go to a facility thinking, okay, I'm concerned for my child, they may be sick, I want to go to this local and a lot of families, it's lost on them the difference between someone who's a pediatrician or pediatric trained with fellowship and things like that versus just a general ER doctor. So I'm really trying to build awareness so that families know to ask those questions. Do you have a pediatrician on staff? What is capability? What is your pediatric readiness? Do you have proper equipment, et cetera, so that they don't get into an issue, really.
I'm always, as someone who spent many years I practice in community pediatric ER, did not practice in academic ER, but and now own a practice. I always find the forces and the reasons why parents end up in the ER somewhat interesting. And in the community setting, at least where I practiced in Metro Denver, it was always, when people would always talk to me about it, I'd always say 80% of our visits were not true emergencies. They're there
Yes.
for other reasons. And maybe 20% had a real emergent medical issue that needed to be seen. So as someone whose career has been very, very dedicated in the pediatric space in so many ways, I'm really interested to hear your views. And I know you practice at many levels. You know, what do you see are the forces that push parents to end up in the ER?
Yeah.
And do you think that and I have my own thoughts about this as someone who now owns a private practice, but I sometimes feel that the system doesn't help
You hit
at
the nail
times.
on the head. That's the leading hypothesis of mine. The system does not help. It doesn't foster proper use of these spaces, unfortunately. So seeing it from both sides, and I'll just say from my side, from just practicing in the I mean, where to begin? How long do we have? But yeah, the first things first, right? The health system that we have in the U.S. If we take it way back, because I try to think of like, further upstream, but basic health literacy in this country is abysmal. Well, you can go through your
True.
whole education and go on to be quote unquote a professional lawyer, engineer, whatever. And unless you start out specific medical classes, I have adults who don't even know what organs they have in their bodies, right? So that's number one. Basic health literacy, understanding basic things about your body for the general population is really poor, unfortunately, unless you go into the medical field. And so, as you
Truth.
can
Yeah.
imagine, that just propagates that level of ignorance. And what do people do of the unknown? They're scared of it. They're fearful of it. So every little thing, the average person, especially when you think about a parent and their child, understandably, they're going to be likely more vigilant or hyper vigilant about things that are
Right.
going.
And by the way, social media doesn't help, and information
There
overload doesn't help.
So it's
And
like all these
and
sound bites
yeah,
and clips of, well, did your child blink 3 times today? Well, that means they might have this.
have this-
And it's like, okay, if you don't have any context or frame of reference, that can spiral out. And so it can be kind of like, these fear mongering, like scare tactics in terms of what could potentially be going on with the child. So I think that's a big part. And then secondly, thinking about the line as well, and you may have experienced this, right? Not as many people are going into pediatrics. There's globally a shortage of healthcare professionals that we've been, especially recently, since the pandemic. But from our specialty, not as many people are going into pediatrics. And again, there are a whole slew of reasons for that. But as you well know, right, pediatrics is not viewed in the same scale as adult specialists. When I talk to my friends about this, they're floored because they're like, wouldn't, like, if anything, they're like, shouldn't a pediatric specialist be paid more than adult in terms of like all the things you have to know and the
well,
time?
exactly. And especially in primary care, no one values the time that it
Exactly.
takes to
Yep,
talk and counsel and teach, which is most of what
absolutely.
non-specialty pediatricians do, and it's just not valued in the system. So
Absolutely. You're exactly right. And again, that's lost on a lot of people. It's like a good pediatrician, you have to spend that time because it's a big education, it's anticipatory guidance, it's counseling, all of this things you mentioned. And you're not being compensated for that. It's not being valued in the healthcare system. So I have friends who would love to spend 30, 45 an hour with their patient, as they rightfully should, because there's a lot going on with the child's development. But they're slammed and they have 6 well visits booked in 1 hour. That's the same to say that you can do your job properly in 10 minutes. And so
you can't.
yes, you can't. You just simply can't.
But then you can't keep your doors open if you don't.
There
It's
is
really, really,
it's a
and lose. And so what happens is then because we lack, because of that, our capacity to absorb urgent questions and urgent visits continues to diminish. Our bandwidth after, because at least in my practice, we have to see patients for 12 hours out of the day in order, our bandwidth to spend 20, 30 minutes on a phone call with a mom who's
out
who
the
has a
window.
fever.
There's no way you can.
Get out. You can't. And so many of us go to nurse triage services simply to preserve our mental health. In fact, if I didn't do that, I'm sure that the doctors that work for me and the providers that work for me wouldn't work for me because they wouldn't want
100%. It's
to
too
say,
much.
okay, you're telling me that after my 12-hour day, I'm now expected to take these phone calls, especially in the winter. They
And
won't do it. So,
it's
the
simple.
whole, I believe the whole thing is sort of designed to push people then into emergency room spaces to limit your liability. And just rapidly give people, to alleviate their anxiety over their non-emergent conditions that you don't have time to teach and counsel and engage them on when they need it, which is after hours and on weekends.
Absolutely. I think you're absolutely right, because it's that cycle, right? If you don't have time during the day and you're a parent, you just came home from your work day and your kids have this fever, it's 8 or 9 p.m. and you can't reach your clinician because their clinician just worked a 12-hour day.
Right.
And nursing triage is saying, oh, have a fever, goes to the ER. So it pushes them into the ER setting, and it's like a quick fix. And so I think that's really lost on families sometimes, because I'm talking to them about, I try to do my piece as a good pediatrician in terms of like education, anticipatory. But they're saying, well, I can't get in with the pediatrician. And I'm like, I'm certain your pediatrician is busting their butt, but just like you said, the incentives aren't aligned with proper care. You cannot,
No.
like you said, spend 30 minutes to an hour with the patient and still keep your doors open in private practice. It's just not tenable and how the
Right.
reimbursements work. And so I think that a lot of these families, I kind of hang it all out there. I have like these mini lectures with the family so they can get a sense of what we're dealing with and the parameters that we have to work in. And because a lot of them just don't know, well, why doesn't my pediatrician have sick visits? And it's like, they don't have the capacity to have sick visits based on the volume they're supposed to see in order to keep their lights on. It's just the math does not work. And a
Right.
lot of families are floored by that because I don't know if you still experience this, but everyone thinks as soon as you're a physician, you're like a multimillionaire. What? One of my friends, it's a joke. They say, the MD stands for $1,000,000. And yeah, no, it doesn't.
Mm.
It doesn't.
Not
Especially
in
in
pediatrics.
pediatrics.
Not in pediatrics.
Exactly.
That's for sure.
And so,
We're all big Subaru drivers.
but so I have taken it upon myself, especially the last few years. I will take a couple minutes extra to really lay the groundwork and give these families insights into how the system is set up and how the clinicians have all of these pressures on us to, like you said, maintain the high levels care, the mental cognition and mental exhaustion that comes with that, while having these parameters that limit actually how you practice good solid
Exactly.
medicine. For that, it really is something that many families are not aware of.
And listen, ideally, all of us, all the pediatricians I know have the capacity to be able to limit these visits,
Mhm.
to limit the amount of time that their patients feel like they have to spend in the emergency room. We all have that knowledge base. We all have that ability. It's we simply can't devote more time and energy and bandwidth,
Yeah.
and that's the problem. So then parents who are, I believe I believe are more anxious. I think that raising kids now is very different than it was 20 years ago. And I think that information overload and
Yes.
anxiety around these things then push them to seek more urgent care in emergency room spaces for non-emergent things. And
And it's the
it,
mentality of the quick
yeah,
fix. This
mhm,
is going on right now. I need an answer right now, and the
right,
culture drives that mentality as well.
100%. And then also, I think one of the biggest, you were mentioning how your company is your parent partners and helping parents understand their child. It sounds like, not just acute things, but also long-term chronic things,
Absolutely. Mhm.
educating them and giving them evidence-based resources, which is amazing. In primary care, I think the two biggest public health issues that inhabit a lot more of our time are the adolescent mental health
Yeah,
crisis
absolutely.
and obesity. I think these are
Mhm.
our two biggest ones. And of and I think where that meets the ER, at least in our community, is the mental health crisis.
Oh,
I
yes.
think that um, Colorado, weirdly enough, has some of the worst adolescent mental health numbers in the country, which is paradoxical because we have beautiful mountains and outdoor
Uh-huh.
activities and amazing weather, yet
Uh-huh.
we have consistently the worst rates of um, crisis use of emergency services for adolescent mental health. We have the highest rates of suicidal ideation. We have some of the highest rates of completed suicide under the age of 16 in the country. Why that has certainly been a big matter of debate. Probably has a lot to do with our cannabis usage in this and how that intersects with adolescent mental health, which is a bigger
Yeah.
topic.
Develop.
But
Yeah.
where do you view the role of the pediatric ER as vis-a-vis the adolescent mental health,
Yeah.
crisis that the entire country seems to be, seeped in?
Yes. So mental health is, as you said, it is a crisis because I think I can even think that just a couple of years when I was in residency, a big children's hospital in Oakland, California, to where the different places that I practice, and it's getting worse and worse in terms of the capacity and resources that we have available to these families,
Right.
unfortunately, which is horrifying because the statistics of the prevalence are only getting higher and higher. So we are definitely not keeping pace with resources that we can offer these families.
Sure.
And depending on the state you're in, it can be better or worse, but just globally for the nation. And so I think that from the standpoint, like the pediatric ER, depending where you are, so I'll take where I am, like a community setting where most of these events occur, it's extremely challenging because we do not have the bandwidth or the resources. So just starting from just from the beginning, right? The medical management, right? The knowledge base for how to manage an acutely psychotic or acutely even suicidal teenager is very limited, right? Unless you have specific training in that. And so that already creates an antagonistic adversarial rapport with the families, like if the family is involved. And then the second layer to that are, right, the resources. I'm on shifts. The patients are continually coming in, right? I can't just say, hey, we have a psych evaluation, close down shop. I can't do that. So a lot of these facilities with a single provider, because for example, where I am, I'm a single provider who's on. So that in terms of our workflow is very, very challenging because you want to address the needs of the patient who's having the psychiatric issues, but it really slams down our productivity. And the reason why I mention that is then all things else will bottleneck. So it really can become a very even unsafe environment if I have a medical issue that I have to attend to that's critical and a psychiatric patient. And sometimes they come in the same person, unfortunately,
Right.
which I've had to deal with. And then the other layer in terms of like our ancillary support, right? The social workers or case managers, or even how do we access a child psychologist or psychiatrist in that setting is super challenging. We've reverted to trying to do telemedicine just because, again, as we mentioned, just like shortage of specialists, things like that. But it's extremely challenging. We've had patients waiting for days, weeks. And it's like,
No,
what does
it's
this do for a child's mental health? You're coming in crisis, and now I'm telling you have to stay in this 8 by 10 room until we can find placement. And so that's why we really are focusing on with parent partners to try to help these families not only help during a crisis or if the child is having issues, but how to engage with them well before then to pick up on the signs and symptoms that there may be some issues going on. Because especially culturally, depending on the family, right, a 6-year-old presents with anxiety and depression very differently than a 15-year-old. How do we help the families feel comfortable to engage with their child in the schools and sports teams and all of that to build a community where there is a network that can help this child if they are having difficulties and pick up on things earlier on before it comes to a head and before it is a crisis. Because once I see them in the ER, I'm very limited in what I can do, and it is hard.
Exactly.
Because these families are at their wits' ends. I have families that come in and say, I've been on a wait list for over 6 months to see psychiatry. And I know it's true. I know it's true. And it's
It
like,
is.
and it's just very, very sad because at the end of the day, it's the parents and the families that are suffering because of these systemic issues.
In our clinic, we actually started our own adolescent mental health, separate mental health clinic, and we work with a community adolescent psychiatrist. And what I've learned through that process is that so much of what you described is this linear process, and kids end up and then you have very few options because of the liability issue and the availability. Most of those kids don't have to end up there.
Absolutely.
So many of us in community pediatrics, once again, have the ability to actually provide pre-crisis mental health care and keep these kids before they get to that point without having to wait 6 months for a psychiatrist. But once again, we're hampered by the inability to spend the proper amount of time that takes.
Absolutely.
Because even if we do, the payer system doesn't reimburse us enough for that 45 minutes to an hour that patient would need to get proper mental health evaluation and a plan together and a follow-up plan together. And so I need to see the 4 ear pains and coughs instead of the 45-minute mental health. And so what happens is then the system relies on less available adolescent psychiatrists. I have a wonderful adolescent double board certified adolescent psychiatrist that says 80% of the stuff that comes to her doesn't need to be seen by her.
Right.
It could be
Like you
seen
said,
by her. But the people who could provide that, once again, are limited by the system that doesn't value that time and makes it, and therefore the access becomes less and less. And then it puts more forward pressure on the ER as the backstop for the crisis, which inevitably is going to happen when things go unaddressed.
Yeah. And I think all of these things we're talking about, I feel like this is why we're just seeing a rise in more or less like concierge medicine, right? If you're blessed enough to have the bandwidth to pay cash or have things being out of pocket, this is what families are seeking because they can know that they're getting the short end of the stick, right? And a lot of these families that they absolutely very much like the clinics they're in, but they understand the time constraints that the clinicians are dealing with. And if I have my choice, am I going to, pay X amount of money to be able to see a clinician for an hour? Or am I just going to go through this cycle of these 10, 15-minute visits and not get the resources I need? So I think that is an extrinsic force that's driving the concierge space. And again, unfortunately, right, that the average person can't afford that. There really is, I don't have the answers in terms of like, how do we move the needle so that they value these types of services that we offer?
Yeah. I mean, I think that this because of these things and the general dissatisfaction, we started our own concierge part because parents, what they discover, what they value is accessibility and your time, none of which are available to the person. And what is frustrating from the parent side, because I also have a large family and we have health insurance, is that the parents continue to feel like they are being charged hand over fist, left and right. They pay their exorbitant monthly premium to cover them and their kids. That goes out of the paycheck. Then their deductible, because there's no such thing as a plan now that doesn't have a sizable deductible. And their copay. And so what we're seeing, especially more since the pandemic, is the families, and these are educated, caring people. Our community is, everybody has college degrees, 2-income households. And so they feel, rightly so, look at all that's going on. I feel like I'm entitled. I feel like I should be getting for my kids an appointment when I want. I feel like I should be getting the time when I want it. I feel I should be able to have all the time on the portal. So the doctors who are also trying to see 30 patients should answer my series of questions on the portal. And I get it, because they see all that money leaving there.
Yeah, like what is the service I'm getting from it? Yeah.
What am I getting? And of course they assume it's going to the physicians, which of course it's not. And therefore it's what I feel has been going on. And in the ER, sometimes I got this too. It's more adversarial between ourselves and our patients because of their experience with
we're the person who's
we're able to deliver and what they feel that they should be getting, which I 100% agree with. They should be getting more.
Yeah.
But we're not able to deliver it.
Yeah. And this is why I have my mini lectures in the ER. I tell it to them straight. I say, like you just said, I agree with you that this is not a good system. I have a family that comes in who the kid had a seizure a week ago. And by the time the clinic was able to get to her messaging a week later, the nursing triage says, go to the ER. And the kid had a seizure a week ago. So the mom, right, so is a little puzzled, but she's like, this is my kid. Okay, I guess I should listen to what they said. She comes to the ER. I was talking to her, kid's fine. But, okay, this happened a week ago. I'm like, well, we can give the referrals to neurology. In full transparency, that's going to probably be 8 to 10 months so you see them. And I don't have any skin in the game. I'm not withholding visits. I'm not hiding neurologists anywhere, but I don't have a secret back line to get you an appointment next week. And I would say 9 times out of 10, hopefully once you can frame it and just be honest about what we're dealing with, most times the families get it that, and I've been able to, just given the role I'm in currently, like, when it's something that egregious where it's like this very easily should not have been an ER visit, I'll be able to work with our financial team to say, please, like, do not charge this copay, because there was a huge miscommunication in terms of the
Right.
management, and this family should not suffer that. But, unfortunately, I'm not able to do that with every family. But like you said, it is very challenging because we're the face of all of these things that's going on in terms of having these long waits, huge co-pays, huge deductibles, and they think that somehow we're in on it, and it's like we're testing it from both sides. Like, we want to be able to deliver the best care possible. We want to
Exactly.
be able to spend time with the families, but the reimbursement and the payer system does not allow for that. If you want to be able to keep the service, the clinic, what have you, open, and
Right.
so now I just am extremely transparent with the families about that, so that hopefully they get a little more insight and understand that we are on the same side. We're working within these parameters that we do not set. That's the number one thing. People think that we've like set this up, and it's like, no, no, no. We're in the system just like you. You guys are consumers, and we work in it, but we're not the ones dictating how it's run, unfortunately.
So if you were, when you're counseling families now, and it sounds to me that you're kind of moving away from full-time clinical practice to devote more energy to these other projects, pen pal and parent partners. How would you best empower families to be able to be for themselves better advocates, and
Yeah.
perhaps and maybe be able to give them the type of information that they would need to limit unnecessary, 'cause there's
Yeah.
nothing more frustrating, I think, or scary or anxiety provoking than dragging your kid to an emergency room, and you go through that, and then you go through the process to get to FaceTime with Dr. Arnold or one of your colleagues to be told, "Yeah, you're fine, thanks for coming in,"
Give
and
it a
then
few days there.
right, and then imagine, from the parent side, because when they come to visit me for the obligatory, "Hey, go see your pediatrician in 3 days," the amount of frustration that comes out, rightly
It was,
so, is gigantic.
yeah.
Because, like, your plan most people's plan is you have to pay that big amount just to get through the ER, but the system told us that this is where we had to be, and when I was facing the clinician, I was told, "Go home," and
Yes.
so there's so ho
Yeah, it's a huge disconnect.
what tools, what resources and tools and advice you can give parents to maybe decrease the rates or chances that that has to happen to them?
So it is challenging. And so what I try to frame it like this, like, and it depends on the population, but I try to give a frame of reference for what each of these spaces is, what your client space is, and what the ER is, or urgent care now. And so I tell them, I say, listen, as a parent, if you feel like there's something life threatening going on, or you're extremely concerned, that's the ER space. It's not because you can't get a visit in the next day, but the kid's like a little not feeling well, but you feel like you can wait a couple of days. So that's number one. I try to just frame what these spaces are and how to try to appropriately use them, within the parameters that we have. The second thing is being trying to use your primary care to the fullest ability. So what I tell families is, you have your well child visit coming up for your 6-year-old in 2 weeks. Really keep a running log of things you want to discuss with your pediatrician, right? Because knowing that you have a limited amount of time with them, focusing in on what those top 3 or 4 things are is going to really help the visit, and you're going to feel like you're getting what you need out of it. Because if you're blindsided, and I understand everyone's busy, 1,000 reminders popping up in your phone, but if you can set time to say, okay, this visit is next week, and these are 3 absolute topics I want to have addressed, that will typically allow you to feel more heard and feel like you and the pediatrician are on the same page. Instead of going in, you have your 15-minute visit, and then as you're driving home, you say, "Ah, damn, I should have talked about how Johnny's not sleeping right." Right. So
Cool.
I try to tell them that little pearl to say, try to prep for it like it's a quiz or a test or something. to have those couple of things that you absolutely want to speak to your pediatrician about. So
Right.
that's one thing. And secondly, outside of I try to give them a frame of reference that we do not have, especially in the community, we do not have a suite of specialists who are just waiting to run down to the ER to see them for whatever complaint they have. And again, I'm certain you don't
Right.
do this, and I have obviously many friends who are general pediatricians, but I think the frame of reference is a little off sometimes. And, you know, I'll say different types of clinicians may set that expectation for the family to say, hey, you have a Caesar concern going on, go to the ER because they have the specialist there. And I'm like, that's not always the case. So know the facilities that are in your area. So
Yeah.
if you are going to a community hospital, odds are we do not have that specialist, that we would probably have to refer you to the nearest dedicated children's hospital. So
Right.
if you have that frame of reference to say, okay, do I think this is life threatening? Do I think this is, really something that can't wait until the morning or whatever? And am I going to the proper facility? Because you mentioned it when we first started talking, right? Families are going to go to the closest facility. It's normal. It's a convenience and access thing. But if you feel like, you know what, I really think that this is concerning enough, but also I know this community hospital doesn't have that. Let me drive that extra 20, 30 minutes to maybe go to the children's hospital so that I can at least feel a little bit more comfortable as the parent. So
Absolutely.
when you try to give them a roadmap, I think most reasonable people can understand that, the spaces for primary care and going to the clinic, and then also going to the ER and try to differentiate and set those expectations as to what you think you're going to get out of the visit. Because if it's just, okay, they're running a fever, gave Tylenol, gave Motrin, yeah, but it's day 2 and they're otherwise looking okay when they're not. So odds
Right.
are I can probably ride this out versus just coming to the ER. I mean, I've had friends that have come and said a kid comes in with a fever and, I give them Tylenol and they look great. And they're like, well, they didn't look like this at home. And I'm like, well, did you try
Yeah.
giving the Tylenol? Did you try giving some Motrin?
Yeah.
These are your best friends. These are over-the-counter things that you can try first before you make this trek over here. But it is
I do have
really,
to
really
say that
challenging.
our nurse triage is run by the Children's Hospital,
Oh, okay.
and so better than most that I've heard about in other parts of the country that are independent.
Yeah.
I have to say that most of the time they do at least give parents those first 2 or 3 steps before they, push
Yes.
them into the ER. And in our practice, we have it set up that if the nurse triage decides that they should go to the ER, they have to at least talk to the physician first and
Thank you.
not just go, because
That's
then I'm
right.
going to say 50% of those visits are then saved by simply having the conversation with the doctor, but it's still not the same as getting hammered with every
Right.
phone call.
Yes.
And
That's
that
very
has
true.
also massively improved our patient satisfaction when it comes to just not feeling railroaded with every phone call, which I see occurs
Oh, very commonly.
not infrequent.
I mean,
If you call after hours, there is
automatically.
this strong automatic bias to send you in without any discussion, which
It's really
not ideal.
unfortunate.
No.
Very unfortunate.
So Dr. Arnold, maybe tell our audience, so parents, where they can find out about parent partners, if you want to give them specifics,
Yes,
and for those of our
absolutely.
audience that are clinicians, where they can learn about PenPal for
Yeah.
the community support. So maybe start with parent partners, 'cause I think that interests more of our audience.
Yeah, absolutely. So you can check us out. We have our website. It's www.parentpartners.co, and we have our full suite of services on there that you can check out and kind of runs through the catalog of programs that we offer and step-by-step directions to download the app so that you can become a member and subscribe. The thing that I really like about Parent Partners is that it's self-paced. So we have even the programs you can kind of hop around depending on what's going on with your child or what you're interested in. And then once you're able to engage with the content, then we can get you on a schedule to do like group visits and whatnot. So you can find that information at parentpartners.co. And you can also find us on Instagram, My Parent Partners as well. We have a page where we post some content and tidbits around that so that they can follow on Instagram as well at My partners. And then for, as I said, it's more hospital facing for pen pal, but I think as I'm speaking with families about it, and they're kind of getting more attuned to the differences in the facilities between community and a children's hospital or the training. Pen pal can be a great resource as well. And our website for that is penpal.co, .co, TEMPAL. And there you can see the testimonials from the work that we've done working at different facilities. And for clinicians, we have an email list, newsletter that we can have you subscribe to for free to just get clinical pearls. A lot of I found the mid-levels or APPs, whichever term you prefer, a lot of the nurse practitioners and PAs that I've engaged with will sign up for a free newsletter so they can get pediatric pearls, just little tidbits, and different content that we've developed around, like, what are normal pediatric vital signs, and what are tips and tricks you can do for splinting, for orthopedic injuries, laceration tips, and things like that. So if you check out penpal.co, you can sign up for the newsletter, and then also just book a free consultation if you are in more of a clinical or leadership role and interested in our services, because we are looking for sites to pilot the clinical decision support tool that we've developed.
Thank you so much for making the time.
Absolutely.
And looking forward to interfacing again and learning more about what you're doing. And I know that our audience appreciates hearing about everything that you're doing. And I think someone from the inside of the pediatric world to help parents understand what seems to be a very opaque and complex process at times.
Absolutely.
And really appreciate you making the time to come talk to us today.
Yes, thank you so much for having me. It was my pleasure. And I always love discussing these topics, and education are just is really important and near to dear to my heart. So thank you so much for having me.
Amazing. And so remember, Your Kids Will Be Fine, available anywhere you find podcasts. Also on our website, yourkidswillbefine.com, where you can download all the episodes and leave us comments as well as future show suggestions. And thanks for joining us, and have a great rest of your Mother's Day and Sunday, Dr. Arnold.
Thank you so much. Thank you.
Take care.